Here's Laura Windsor now with a report on preparing for breast cancer treatment.
According to the American Cancer Society, preventing and detecting breast cancer early will help save more lives. We spoke with Dr. Janet Ihde at Desert Regional Medical Center in Palm Springs, who gives us more on what to do before breast cancer surgery.
Prior to surgery now, there's a big push to do chemotherapy or anti-estrogen therapy depending on the cell type and the marker status of the tumor. They're looking very closely at all the different types of cancers, getting more personalized therapy to shrink the tumor. This is also indicated in patients not only who have large cancers in order to allow easier surgery with cleaner margins. It's also used in patients who have a lot of bulky abnormal lymph nodes in the axilla. This is called downstaging the tumor. This is becoming more and more popular, and it depends on not only the type of cell, for example ductal or lobular, it's depending now on subtypes like luminal A and luminal B. The patients who have very aggressive cancers will respond very quickly to chemotherapy. These patients have a complete response rate in which the tumor disappears. The surgeon then has a marker placed by radiology before treatment that allows them to go in and take out tissue in that region to make sure the cells are all gone. The patients also who are estrogen receptor positive, in other words, they have that little molecule receptor that is sensitive to estrogen that's circulating, and the estrogen locks onto that receptor and causes the tumor cell to grow, would benefit from an anti-estrogen medication like tamoxifen before surgery to shrink up the tumors as well. If someone presents with a low-grade stage 1 breast cancer, these patients are not particularly sensitive to chemotherapy, and they would best be addressed with surgery first, making sure we analyze both breasts, make sure there's no other indication to do mastectomy, and these patients are good candidates for doing lumpectomy with radiation in addition to the sentinel node analysis, or the first node that drains the breast. The neoadjuvant chemotherapy treatment actually started with what we call inflammatory breast cancers decades ago, in which patients received chemotherapy first, allowing us to do mastectomies with clear margins. Now they're using chemotherapy to treat cancers, not just to shrink the tumor to allow for breast conservation, but also to provide information on the sensitivity of the tumor to different treatment agents. Just a few years ago, there was a 20% complete response rate. Now there's up to 60% complete response rate with the newer types of regimens of treatment. And this impacts what the surgeon is going to recommend to the patient. If I see a patient that I think qualifies for what we call the neoadjuvant program, we collectively look at the patient, make a decision as to the best way to approach this. If the medical oncologist feels that the patient would benefit from chemotherapy first, they would start their chemotherapy immediately, and we would both be monitoring the response to determine when the patient would be ready for surgery. After surgery, the patient usually goes to radiation therapy, providing the patient has breast conservation or had a large cancer or a lot of lymph nodes. And even that's changing. Radiation oncologists would be able to tell you that radiation now can be delivered in a little higher doses over a shorter period of time. We're seeing longer and longer time of survivability without any cancer. These cancers may recur very late, but there's a significant number of patients that are now being able to be cured with this regimen that were not able to be cured before.
Remember, early detection for breast cancer saves thousands of lives each year, so make sure you go for your mammograms and proper screenings to detect any problems early. For the American Health Journal, I'm Laura Windsor.